So with that, let's start the discussion. Javed, you mentioned about STEP HF and you answered most of the questions that I was going to ask you. But I will still ask you. First of all, it was a small trial. There were no endpoints, the hard endpoints were not there. So why is it not just obesity reduction? The only thing I could make out was the anti-proBNP, which fell down despite them losing weight. We know that CRP will also, obesity is also a pro-inflammatory state. If they lose weight, CRP levels will come down, exercise tolerance will improve. So despite whatever you have shown, rest of it is, the analysis or mechanisms of action. Why is it not just weight loss?
So I don't know. I think that the fact that the heart failure hospitalization were 12 to 1, again, I have no idea what to make of such small numbers, but at least it all goes in the right direction. I mean, there are two ways to look at it, right? So one is to say, well, this debate is sort of not helpful because, okay, fine, even if it's just obesity reduction and not heart failure pathophysiology difference, if a patients are feeling better, then that's sort of good enough. Another way to look at it is that if a person doesn't want to take medication lifelong and they want to just get bariatric surgery and they'll just lose the weight from bariatric surgery, do they still need semaglutide? And the question is, if their BMI goes to less than 30, the answer is absolutely not. The bigger question that we will have to contend with is that I very flippantly said, lifelong semaglutide. I mean, when they do take the drug and their weight comes to less than 30, are they able to maintain it without semaglutide? And that's a whole different question that we really haven't answered yet. So there are a lot of questions. So I really appreciate your caution not to overestimate a 500 patient study. I think with all the other studies coming out, we will get more results. But that's the best way to interpret the result that I can do.
Is there any data, Javed, on what happens to anti-proBNP levels with bariatric surgery?
So I don't know. In the look-ahead trial, which was exercise and diet, the BNP levels, anti-proBNP levels went up. I actually don't know with bariatric surgery. I would suspect that the levels go up, but I don't know.
Considering the obesity paradox, is there a difference between intentional weight loss and that which happens due to disease?
So that's actually an interesting question. So there is a concern on the basis of two trials, LIFE and FIGHT trial, that GLP-1 receptor agonists are associated with some modest increase in heart rate. Heart rate in HFrEF has never been a good sign. And both the trials, neither of the trials were powered for clinical outcomes, but the trial basically showed that the clinical outcomes went in the wrong direction. Now, those trials were in HFrEF and had nothing to do with obesity. I almost feel that now I'm going to sort of talk from both sides of my mouth and say exactly the opposite of what I said 5 minutes ago, that maybe there is no obesity phenotype of HFpEF, and maybe it is just obesity phenotype of heart failure, and that even HFrEF patients with intentional weight loss will do well. The traditional thought was that HFpEF patients are obese, whereas obesity is not very common in HFrEF. I can tell you, I don't know about Europe or Asia. In US, there is plenty of obesity in HFrEF population now as well. And I think that it's really a worthwhile question to look at the risk-benefit ratio in obese HFrEF patients as well overall. So I think that all of these things will need to be sorted out over time.
So, John, based on STEP-HF trial, from tomorrow, are you going to start prescribing semaglutide to your obese patient with HFpEF? Or you'll wait?
I would think about it if there was a supply available, and B, if it was funded by the Scottish National Health Service for those patients, and it isn't at the moment. So I can't is the simple answer. But would I like to? Yes. I mean, I don't really care how it works to some extent. And again, that's a flippant answer, but that was a whopping improvement in KCCQ. What was it, Javed? 16 points or something? It was incredible. And okay, you might say there wasn't blinding or whatever, although I don't know if this is true or not, Javed, but I heard there was some attempt to assess whether or not patients were blinded to what treatment they were getting. And in fact, the patients weren't very good at determining whether they were on active treatment or placebo. I don't know if that's right or not, but if that's true, it's even more interesting. So, I mean, there's nothing I've seen that isn't good about this, and the drop in NT-proBNP to me is the big surprise, because in clinical practice, if you manage to get patients to lose weight, usually their NT-proBNP goes up. So to me, that suggests that there's something else going on here. Don't know, is a GLP-1 receptor agonist has it got vasoactive properties? Is it a vasodilator? It seems to me that there must be something more going on. And also the small rise in heart rate. And I don't know, I can't remember, Javed, whether heart rate went up in this trial.
Yes.
But I mean, there's so much interest now about many patients with HFpEF having chronotropic incompetence and maybe being on a beta blocker, which many of them are, not being a good thing, that actually even in HFpEF, a small rise in heart rate might not be such a bad thing. So I haven't seen any negatives. I mean, maybe I've just not read it carefully enough, but everything to me looks good. Of course, we need to see phase 3 morbidity mortality trials, but from what I've seen so far, if this was free and widely available and you could give it to your patients, then I have difficulty in seeing why you wouldn't give it to your patients.
Yeah. So John, you mentioned about the combined analysis of Paraglide and Paragon, but that signal came out from Paragon itself, women and patients who were recently discharged from heart failure. So that is a stronger indication for using these patients. Would you say that?
Well, I think so in terms of recently hospitalized, I think that's probably just a phenomenon related to the event rates in those patients and the concentration of events in people who've recently had decompensation. And I think we've pretty much seen exactly the same thing with SGLT2 inhibitors. It's probably not, and in fact, also with MRAs. So it's probably not a treatment-specific thing. It's probably to do with the fact that if you've had recent decompensation of your heart failure, you're at very high risk, and it may be easier to show that an effective therapy works in those patients than in patients at lower risk of fewer events. I think it's probably that. Maybe there's an element of some of these therapies having a decongestive effect, which might also be more prominent in somebody who's recently been decompensated. The women thing is interesting because, again, I don't know whether it's real or whether it's a fluke finding. And I also have great difficulty disentangling it from the ejection fraction finding because, of course, women have higher ejection fractions. So the fact that sacubitril/valsartan seems to be more effective in women than in men to a higher ejection fraction may have something to do with the fact that women have a different ejection fraction range, and that a woman who has an ejection fraction of 60% may effectively have reduced systolic function, whereas a man with an ejection fraction of 60% might have more or less normal systolic function. So because the ejection fraction range is shifted, disentangling sex and ejection fraction, I think, becomes very difficult. So I really don't know how to disentangle those two things. And by the way, again, we've published it only in letter form, but you do get a similar sort of picture with other neurohumoral therapies that we've been able to analyze. So candesartan, mineralocorticoid receptor antagonists, you get the sense that those splines that I show you that sort of go diagonally upwards across the range of ejection fraction, they're shifted to the right in women compared to men.
In recently hospitalized patients, could it also be that they have much more neurohormonal activation because of the recent heart failure, and therefore ARNI is more likely to act in them, even with
Could be, but we also see that somewhat greater absolute risk reduction with SGLT2 inhibitors in people who've been recently hospitalized. So we don't think SGLT2 inhibitors work through neurohumoral mechanisms. So again, it's either something to do with the event rate in those patients, and therefore making it relatively easier to demonstrate benefit in higher risk people, or possibly, as I said, something to do with decongestion.
So one question which is, sorry, go ahead.
No, I was going to say maybe Javed might have an
Javed?
alternative explanation for that.
No, I mean, if we tend to not talk about pioneer trial as much, but I mean, talk about impressive results, right?
Yeah,
So I mean, there's something about these worsening patients that they really benefit, and whether they benefit through different mechanisms based on RNA versus SGLT2 inhibitor. But I mean, yes, starting early in sicker patients seems to be really beneficial.
So question to both of you, something which is often asked. What about using RNA and SGLT2 inhibitors in patients who are already on dialysis? I mean, at least if they get, I mean, if they're in severe heart failure, are we not justified in using these patients, although it is not there in the guidelines?
Well, I'll take a stab and then Javed can give you the right answer. So I would say that there are ongoing trials with both of those treatments in patients on dialysis. So that's the first thing to say. Hopefully we will get some sort of answer. But I think there's quite a lot of anecdotal experience of using sacubitril/valsartan in patients on dialysis. I think the two problems that you've got to be aware of are interdialytic hypotension and possibly hyperkalemia. But there's a whole, somebody asked me this question recently and I looked up and there's maybe 12 or 15 case series written about this. So I think there is experience of using sacubitril/valsartan. I do it myself occasionally. SGLT2 inhibitors, things completely different story. I mean, I find it harder to believe that those drugs will work in all patients on dialysis. The renal physicians that I've talked to have a theory that in people who continue to have renal function, who continue to produce urine despite being on dialysis, that they might benefit from SGLT2 inhibitors, whereas patients who are anuric or anephric are probably not going to. Don't know whether that's true or false, but there is a trial, the name of which I'm blocking on, which is actually looking at this. Hiddo Heerspink is running that out of the Netherlands. But Javed, you might know more.
No, I have really nothing to add. I mean, the safety profile, you would think that SGLT2 inhibitor with the dialysis patients and their heightened risk and the safety of SGLT2 inhibitor from a renal perspective would be a pretty reasonable thing to do. But at least in the US, there is a specific FDA PI specifically says not to use it. So until more data comes out, there is a specific recommendation to not use it.
I've remembered the name. The trial is called the Renal Life Cycle Trial. If anybody's interested, they can look it up in clinicaltrials.gov.
Okay, I think we are almost towards the end of our allotted time. What about, provocative question. We are told that these drugs should be continued if you have started them with an EGFR, say 35, and EGFR has come down to 15, you should still continue to use them. Why not starting them when the EGFR is already 18?
And the EGFR is already 15.
Yes.
Well, I think we sometimes do. I'm not advocating it something that you would do in everybody, but the problem about that obviously is that you're so close to the threshold for considering dialysis, and I know dialysis isn't about a number, but in practice it often is, and it's very easy to tip patients into the range where then you might have to consider dialysis. I mean, I have sometimes done it, but under very, very close observation, because you need to be really sure that the patient's EGFR doesn't go below 12 or something like that, because then you are likely to get into trouble. So I think it's probably not something to do on a general basis. It's probably something to think about very, very carefully, weighing the balance and risk for the individual patients, something to perhaps discuss with your nephrology colleagues. They're probably doing it even more than I'm doing it. They seem to be less bothered by it. But it's not, I don't know of any, well, before I say something stupid, I'm not aware of any country where you can give an SGLT2 inhibitor below an EGFR of 20, but maybe there is a country like that somewhere in the world. Javed, would you know of any, or what's your view about that?
I mean, so look, I mean, we practice medicine keeping multiple things in our mind. So one is sort of the legal concerns and using it in contraindicated patients. On the other hand, you use your best clinical judgment. We all use beta blockers and ACE inhibitors and all of those drugs in patients that were not included in the clinical trials. The best indirect answer I can give you is the STOP ACE trial. And the whole idea in the STOP ACE trial was that when the GFR goes down, if you were to stop ACE inhibitors, then you will lengthen their time to dialysis, whereas continuing ACE inhibitors. So that trial, I'm recollecting from memory, please double check it, but I think the median EGFR was 18. So the inclusion criteria was GFR less than 30, median was 18. And half of them continued ACE inhibitor and half of them ACE inhibitor were discontinued. And guess what? There was no difference in time to dialysis between the two groups, but the cardiovascular events were lower in those patients that continued ACE inhibitor. So I would say clinically, it makes sense what you're saying. But of course, there are local guidelines, local legal considerations, and all that kind of stuff that you need to just use your best judgment.
So Vijay, I'm taking over your role as chair, but I want to ask Javed one question. Javed, I give you my perspective on this. Is there an EGFR threshold beyond which there's probably no benefit of sacubitril valsartan? And I've heard this debated a lot. There's different labeling in different parts of the world. What's your view about that? Or maybe what's the prevailing view in the US? Would people use it above 60%, for example, as is permitted, I believe, by the labeling in many countries, including, I think, the US? Or are people sort of more cautious than that?
I mean, I think that on the other end, we were just having a discussion about EGFR. I think people would routinely use it for GFR less than 30, not less than 20, but in that range, sicker patient.
Yeah, sure, I agree.
No question. But EF, for whatever reason, I think there is no sex differentiation in clinicians' mind about male, female, EF different. And I think it's pretty much 55 and less, maybe even not,
so same
maybe
sort of,
not even 60.
Yeah, okay. Interesting.
I think if I complete my questions, it's going to take another hour or so. Thoroughly enjoyed the discussion and I wish it could go on forever. But I think we are past our time. So thanks a lot, John and Javed, for your wonderful discussions and for enlightening us with all your knowledge. Thank you so much. Look forward to meeting you again.
Bye, Javed.
Bye, John.
Bye.
Saurabh?
Oh, yeah, thank you, Dr. Chopra. I think I can't thank you enough for actually not only just conducting this program, but also taking really an active role in organizing it. So, yeah, I'm Dr. Mishra. Would you like to say something?
Not at all. We had a wonderful evening. We had a very good, interesting topics and really thoroughly speaking on that. I thoroughly enjoyed it. Some of the new introductions of the newer devices and, of course, new insight into some of the drugs. Very interesting. And I think you put together a very nice program.
Thank you so much. And Soumitra, hi.
Yeah, thank you, VK. I mean, excellent as usual. And thank you, Professor John and Javed. And thank you, team of Shubro and Dr. Anil Mishra. I mean, excellent day. And we come to the successful conclusion of the first day.
And before we end, I
Good
think
night.
we need to, for the delegates that we are starting tomorrow at 10 o'clock, day 2. Okay, bye-bye.
Let's see you. Bye.
Bye. Good night.
Good night.